Bismillahirrahmanirrahim. Good morning, ladies and gentlemen. This lecture is made specially for the FCPS residents who are appearing in their exit dermatology examination. The plan of my presentation will be to take you through both inflammatory and non-inflammatory dermatoses according to their location. So the important or significant feature of this presentation is that I will be teaching you the tips of dermatopathology diagnosis during the examination while keeping the order intact, that is, from the top to bottom, whether you are viewing the histopathology slides on a microscope or you are seeing it in front of your computer screen, you are always going to see the slide in a methodical manner from the top to bottom. This is a quick revision of the normal histology of the skin. From the top to bottom, the first layer is stratum corneum, which in normal cases is a basket weaving as apparent in the slide. Then after the stratum corneum, the next layer is stratum lucidum. This is a little dense eosinophilic, rather thin layer, and it is present only on palm and soles. Then comes the next layer, which is stratum granulosum. This is also known as the granular cell layer. This is different from the other layers of the epidermis that the keratinocytes in the granular layer have the vacuoles or granules, which are known as the odd-line bodies. And because of the presence of these granules, this layer appear more basophilic than rest of the epidermis. Then the main bulk of epidermis is occupied by stratum spinosum, also known as the spinous cell layer. And the significant feature of this layer is that the cells in stratum spinosum are polygonal, having different facets, and are attached to each other by desmosomal connections. Then the last layer of epidermis is the basal layer or stratum basal. Stratum basal contain the keratinocytes, which are a little columnar in shape. And after every 5 to 6 keratinocytes, you will find a melanocyte, which will be different from the rest of the keratinocytes by its darkly stained nucleus and a halo surrounding the nucleus. Then comes the dermis, and dermis comprises of two different types, two different layers. The first is the papillary dermis and second is the reticular dermis. The papillary dermis is almost 1/10 of the size of the whole dermis, and it is the little denser collagen bundles which are present just beneath the epidermis. The portion of papillary dermis that is going into the epidermis is called as the dermal papillae, and the portion of epidermis that is going into the dermis is known as the retiridges. So remember, the retiridges are from the epidermis and dermal papillae are from the papillary dermis. Beneath the thin layer of papillary dermis, the whole of the dermis is called as the reticular dermis. This dermis has thick collagen bundles, which are relatively loosely dispersed in the dermis. Now we are going to start from the topmost layer of epidermis, and we are going to discuss the different pathologies which you encounter in these layers and how does these pathologies correlate with your final histopathological diagnosis. So in the stratum corneum, we can see hyperkeratosis, parakeratosis, follicular plugging, Monroe abscesses. We can see hyphae and spores, or there can be a subcorneal split or a subcorneal blister. If split is seen, then we need to determine the cell contents of the split. So the first slide is that of hyperkeratosis. I showed you the first image of a normal stratum corneum, which is characteristically of a basket weave shape, that is like the old baskets which were made of cane baskets. But in hyperkeratosis, this stratum corneum is thick and densely placed. And this hyperkeratosis is a feature of all the keratinizing disorder of keratinization, like ichthysis, like keratodermas, like pityriasis rubra pilaris, like viral wart, seborrheic keratosis, epidermal nevus, cutaneous horn, and in actinic keratosis if it is a hyperkeratotic type. So, if you find a thick stratum corneum in a histopathology slide, it will automatically ring the bell. It should automatically ring the bell in your head that we are dealing with some hyperkeratotic disorder. If the stratum corneum is carrying nuclei, which should not be usually present in stratum corneum because the process of keratinization or maturation, the keratinocyte from the basal layer loses its nucleus till it reaches the stratum corneum. And usually stratum corneum contain dead keratinocytes, which we saw in hyperkeratosis. So if the nuclei, the keratinocytes in stratum corneum are retaining their nuclei, it can be focal, it can be diffuse, and this feature is called as the parakeratosis. The parakeratosis usually signifies disturbed keratinization or disturbed maturation of keratinocytes. The disturbance can be because of increased number of keratinocytes entering into the mitosis or by shortening the cell cycle time. So parakeratosis is one of the most typical feature of psoriasis, any type of psoriasis. Then you can see alternating hyper and parakeratosis in PRP. Focal parakeratosis is seen in P. rosea, in pityriasis lichenoides chronicus. In actinic keratosis, it is also common to find both hyper and parakeratosis. Similarly, the alternating hyper and parakeratosis is also seen in inflammatory linear verrucous epidermal nevus. And in porokeratosis, you see a single column of parakeratotic cells invaginating the epidermis at an angle. This is a focal parakeratosis. You can see this focal parakeratosis in guttate psoriasis, in pityriasis rosea, and in PLC. So if you see a focal parakeratosis, these three diseases should ring the bell. Again, focal parakeratosis, all these three conditions should be remembered. Here you can see that there is follicular plugging. Plugging of the follicles means that there is a thick stratum corneum or thick plug of keratin, which is occupying the follicular opening. And this follicular plugging is a typical feature of a few skin conditions like discoid lupus erythematosus, lichen sclerosis atrophicans, keratosis pilaris, and lichen planopilaris. So there are not many conditions in which the significant finding of follicular plugging is seen. And if you find a follicular plugging in a stratum corneum, these 5 conditions should automatically come into your mind. This is a big follicular plug seen in one of the large hair follicle and is a typical feature of keratosis pilaris. There is no other finding except this follicular plug. Then you can see this, this is an appearance in which you can see a big follicular plug that is comprising of some necrotic debris, and the follicle beneath is also showing some damage. You can see the damage, and this actually is one of the perforating condition known as perforating folliculitis. So perforating folliculitis is characterized by a follicular plug comprising of dead necrotic epidermis with, in addition to that, the underlying follicle also show some damage of the basal layer and rest of the epidermis of the follicle with some transepidermal elimination. This is the stratum corneum in magnification, and the thing which is noticeable are the small spores and hyphae seen in the stratum corneum, and this is actually the dermatophyte infection. If we go do a PS stain, then these dermatophytes are more visible. In examination, it is unlikely that you would receive a slide with PS stain because it will make the diagnosis too easy. This is again a very interesting slide. And if you see the stratum corneum, you will find the cross-section of Sarcoptes scabiei. And this is a typical burrow in the stratum corneum where two Sarcoptes scabiei are present. In addition to that, the female Sarcopte is also laying the eggs. So this is a picture of scabies. Now the feature we are going to discuss now is the presence of neutrophils in the stratum corneum. So this is a feature which is seen in many different skin conditions, and like subcorneal pustular dermatosis and pustular psoriasis, and even in IgA pemphigus. Here you can see these parakeratosis and the Monroe's abscesses in the parakeratotic column. So Monroe's abscesses is a feature of psoriasis, and these are actually the neutrophils which are present in the stratum corneum. So if the Monroe abscesses are associated with parakeratosis, then it is typically psoriasis. And if neutrophilic abscesses are seen in hyperkeratosis without any parakeratotic columns, then the diagnosis is likely to be a fungal infection. So you should differentiate these neutrophils from the nuclei of the parakeratotic cells, because the parakeratosis, in parakeratosis, the nuclei are elliptical or longitudinal, are present along the long axis of stratum corneum, while the nuclei of neutrophils in Monroe abscesses are small and round nuclei. This is a typical appearance of corons, which is a feature of porokeratosis. Coron actually comprises of, this is a typical feature of conoid lamella. Conoid lamella, which is seen in porokeratosis, and choroid lamella is comprising of a parakeratotic column that is invaginating the epidermis at an angle. So choroid lamella is a feature of porokeratosis, but is also seen in certain other conditions like in actinic keratosis and viral wart. But in exam, you will find a choroid lamella only in porokeratosis. In this picture, there is alternating column of hyper and parakeratosis. And in addition to this, there is no significant inflammation, and there is epidermal hyperplasia and intact granular layer. So this is a typical picture of pityriasis rubra pilaris. Another picture similar to pityriasis rubra pilaris, but it is associated with significant inflammatory infiltrate. You can see the hyperkeratosis, alternating parakeratosis, and some neutrophils as well. Underlying, there is hyperplasia, which is rather irregular, and inflammatory infiltrate is also seen in the dermis. So this is a typical appearance of inflammatory linear verrucous epidermal nevus. Now, another interesting picture. This picture shows the parakeratotic column and hyperkeratosis. Epidermis is not very hyperplastic, and you can see some kind of dysplasia in the lower layers of epidermis. So this is a picture of actinic keratosis. Now we are done with stratum corneum, and we have reached to the second layer of epidermis, that is stratum granulosum. Stratum granulosum does not have lot of pathologies as far as the examination slides are concerned, but you can notice a few things in stratum granulosum. The first is hypergranulosis, that is thickening of stratum granulosum, or absence of stratum granulosum, which is seen in any condition in which there is dyskeratosis or some abnormality in keratinization. Then the last thing which is noticeable is split at the stratum granulosum, which is seen in all the conditions which are labeled as epidermolytic conditions. The hyperplasia or thickening of stratum granulosum is usually associated with all the conditions which are associated with thickening of stratum corneum as well. So all the hyperkeratotic conditions in which there is hyperkeratosis, there will also be hypergranulosis, because it means that the keratinization is occurring slowly, gradually, with peace, with ease. So lots of stratum granulosum is made and lots of stratum corneum is made. So both these two layers will be thick and prominent. So the differential diagnosis of hypergranulosis is almost same as the differential diagnosis of hyperkeratosis. That is, the keratodermas, lichenification, ichthysis, and one of the typical skin condition known as the lichen planus. So in lichen planus, there is focal hyperkeratosis, hypergranulosis, but it will not be a diffuse hypergranulosis. This picture shows a split at the level of stratum granulosum. This is seen in a lot of conditions which are known as the epidermolytic conditions. The most typical is chronic bullous ichthyosiform erythroderma, or linear verrucous epidermal nevus, epidermolytic keratoderma, and epidermolytic acanthoma. How you will be able to differentiate this split in stratum granulosum from a subcorneal split is, in a subcorneal split, the stratum granulosum will be intact and will be seen at the floor of the split. While in epidermolytic condition, where the split is in stratum granulosum, you will not be able to appreciate any stratum granulosum in the slide. There is no stratum granulosum. Now, there are a few other conditions in which the granular layer becomes a little more prominent. And these are actually the coelocytes, which are the virally infected keratinocytes present in the viral warts. So these coilocytes have a few characters. That is, they are associated with viral inclusion bodies, which are present both intranuclear and intracytoplasmic, as well as a halo around these nuclei. So presence of the coilocytes in stratum granulosum points towards the diagnosis of viral wart. It can be a hyperkeratotic wart, like a common wart, a filiform wart, or a plain wart, in which there will be coilocytes, but there will be a very small, thin layer of coilocytes. Now, another typical condition in which the viral inclusion bodies are present within the cytoplasm of the keratinocytes, and the nuclei are displaced to the side of the cell membrane because of this viral inclusion body. And this is typically molluscum contagiosum, and it is present in form of a crater, and clinically you see umbilicated papule, and this umbilication is actually this crater, which beneath which you will be seeing these viral inclusion bodies within the cytoplasm of keratinocytes. It is involving the stratum granulosum and even involving the stratum spinosum. Now comes the stratum spinosum, the third and the most important layer of the epidermis. In stratum spinosum, you find thinning or atrophy, or thickening or acanthosis. If you see acanthosis, then you would also like to comment then how whether it is only acanthosis or is the thickening going towards epidermal hyperplasia. Then there is another term which is used, which is called as papillomatosis. I will explain to you what is papillomatosis, which is also called as the church spire appearance or the tinting. And then in the stratum spinosum, you are also going to comment whether the dermoepidermal junction is intact. Sorry, whether the desmosomal junctions are intact, or is there any spongiosis or intercellular split. So here you can see that the epidermis is relatively thinned out and there are no ratty ridges. So flattening of ratty ridges is a feature of epidermal atrophy, which is actually the atrophy of the stratum spinosum. And atrophic skin conditions are systemic sclerosis or scleroderma, lichen sclerosis et atrophicans, lupus erythematosus, atrophic lichen planus, atrophoderma, or it can be iatrogenic. So these conditions, which I have just mentioned, should be remembered in the differential diagnosis of any histopathology slide in which you notice epidermal atrophy. There is another slide now in your screen in which you have to notice a few typical features. The first is the epidermal atrophy with loss of ratty ridges. Then there is a dense zone of hyalinization. This hyalinization is different from the normal dermis because here there is no particular definition of collagen bundles like you can see here. So these collagen bundles are all smudged into each other, giving a hyalinized appearance. And then there is a third zone, which is a zone of inflammation, a band-like zone. So these typically three zones are a feature of lichen sclerosis et atrophicans. That is the epidermal thinning, the zone of hyalinization, and then a band-like lymphohistiocytic infiltrate. The slide on your screen again shows epidermal atrophy, but now there is no zone of hyalinization. Rather, the collagen which is present in the dermis is thick and hyalinized, but you can appreciate the individual collagen bundles. So this is a case of hypertrophic scar, or keloid. Now, these two images differentiate between the different types of epidermal hyperplasia. The picture above shows even or regular epidermal hyperplasia. This is a feature of psoriasis, pityriasis rubra pilaris, and pityriasis rubra pilaris, while the picture below shows uneven or irregular epidermal hyperplasia. Here, it's quite striking that this is very regular and this is very irregular. In addition, you can also find spongiosis here. So this, the picture below is that of acute on chronic eczema. This image shows thick hyperplasia, thick hyperkeratosis, then prominent stratum granulosum, then irregular epidermal hyperplasia, without any parakeratosis, Monroe abscess, or any other inflammatory cell infiltrate. So this is a picture of chronic lichenification or chronic lichenified dermatosis. These images are of a benign lesion from the epidermis. You can see clinical appearance, which is of a red papule or a nodule, and the typical feature in epidermis is presence of clear cells in the keratinocytes, which are the glycogen-containing cells. These clear cells have sharp boundaries between the normal epidermis, and this is the clear cell acanthoma. The image you are seeing now is that of hyperkeratosis, but in addition to hyperkeratosis, another feature which is noticeable is the tenting of epidermis upward, like church spire, which you have seen the minarets of a church. They are conical like this, and this is also known as the papillomatosis. And in this image, you see another important feature, which should be appreciated because this is a very typical and diagnostic feature of eczema. And this is the widening of intra-epidermal junctions or desmosomal junctions, which are becoming more prominent. And this widening and this increased visibility of desmosomal junctions is known as spongiosis. In addition to the spongiosis which is seen in the epidermis, there are two large intraepidermal vesicles or blisters which contain serous fluid and inflammatory infiltrate. So this is a typical appearance of acute eczema. The desmosomal conjunctions and spongiosis is highlighted in this picture. Here you can see the hyperkeratosis superficially and spongiosis with neutrophilic infiltrate in upper portion of the epidermis. This is spongiform pustule of Kogoch, which is a typical feature of psoriasis or pustular psoriasis. But you must appreciate here that there is hyperkeratosis superficially, and beneath the hyperkeratosis, there is this spongiform pustule of Kogoch. So this appearance is of AGEP, acute generalized exanthemic pustulosis, which is different from the pustular psoriasis in that in pustular psoriasis, you will see parakeratosis and spongiform parakeratosis, Monroe abscesses, and spongiform pustule of Kogoch, while in AGEP, there will be hyperkeratosis with underlying spongiform pustule of Kogoch. In stratum spinosum, you will also see a split. If the split is present in the epidermis, you need to determine the exact level where the split is present, whether it is in subcorneal or it is intraepidermal or suprabasal. The cell contents of split is also important, and also it's important to find the acantholytic cells within the split. So this is typically a subcorneal split in which there is a very thin layer of epidermis on the floor, on the top, and most of the epidermis is present at the floor. In addition to that, the few keratinocytes which have left the epidermis and have acquired the round shape is also present in the split cavity, and these cells are known as the acantholytic cells. So this image is that of pemphigus foliaceus. Now, here in this picture, there is a large subcorneal split, but in addition to the split, you see these acantholytic cells and lots of neutrophils. So a subcorneal split with acantholytic cells and with neutrophils is a feature of IgA pemphigus. If you see the subcorneal split with lots of neutrophils but no acantholytic cells, then it will be subcorneal pustular dermatosis. This image is a feature of a very typical skin condition, which is Hailey-Hailey disease. So in Hailey-Hailey disease, there is acantholysis, that is breakage of desmosomal junctions, but the acantholysis is not diffuse or uniform, it is irregular, and which is also known as the partial acantholysis, and this appearance is known as the dilapidated brick wall appearance. Similarly, what we see in old ruins of a building, that is the few bricks are lost and few bricks are intact. So this is a dilapidated brick wall appearance in Hailey-Hailey disease. This is again a picture which I have shown a few images before, intraepidermal vesicles with serous exudate and inflammatory infiltrate with underlying spongiosis. So this is acute eczema. Here you see the split is suprabasal. Basal layer is intact, but it is seen like individual cells that are attached to the dermal papillae. The individual cells are not even attached with each other. So the desmosomes are completely lost, but the hemidesmosomes, which are attaching these basal cells to the dermal papillae, are intact. In addition, you see lots of acantholytic cell in the blister cavity, and most of the epidermis is seen at the floor, at the roof of the blister. So this is a typical picture of pemphigus vulgaris, but is also seen in paraneoplastic pemphigus, in Hailey-Hailey disease, in Darier's and Grover's disease. Suprabasal split. This is appearance of Darier's disease, in which there is a follicular plug and suprabasal split with acantholytic cells. Now, the subcorneal blister in pemphigus foliaceus is compared with suprabasal blister in pemphigus vulgaris in this image. In stratum spinosum, we can also see a single cell or diffuse epidermal necrosis. This is, in this image, you must notice a few significant features. The first, there is hyperkeratosis. The granular layer is intact. There is no existing basal layer. since the basal layer comprising of uniform columnar cells, so you cannot find any columnar cell here. Rather than the basal layer, there are cells with a lot of water content, which is called as the vacuolated cells. So this is also known as the basal cell vacuolar degeneration. So basal cells are completely lost here. In addition, the pigment, which should be present in the melanocytes, has fallen into the upper or papillary dermis. In addition, you also notice these pink cells in the epidermis, and these are the necrotic cells, also known as the single cell necrosis. And the necrotic cells are also seen at the basal layer, and these necrotic globules at the basal layer is known as the colloid bodies or civet bodies. There is no inflammatory infiltrate in the dermis, no infiltrate in a band-like manner. So this is actually, the slide is only highlighting the basal cell degeneration and single cell necrosis. So this image is a typical image of erythema multiforme. Now this is the advanced form of erythema multiforme, that is Stevens-Johnson syndrome or TEN. You can find a large split, which is the subepidermal. Whole of the epidermal, the floor of the split is made up of dermal papillae. There is no basal cells attached to the dermal papillae, while the epidermis loses its definition. There are no well-formed keratinocytes, no desmosomes. Rather, the whole epidermis is necrotic. And this is a typical feature of Stevens-Johnson or TEN. Again, the slide highlights the necrotic or dead keratinocytes. So this image shows full thickness epidermal necrosis. And the differential diagnoses which are mentioned in this image are Stevens-Johnson syndrome, toxic epidermal necrolysis, acute graft versus host disease, pemphigus paraneoplasticus, and necrolytic migratory erythema. So these are the very appropriate differential diagnoses of full thickness epidermal necrosis as seen in this image. In stratum spinosus, in addition to spongiosis, there will be an inflammatory infiltrate. And by presence of this inflammatory infiltrate, we can differentiate among different conditions which are associated with spongiosis. And we also should note whether the inflammatory cells present in stratum spinosum are atypical or not. So this is a picture in which you can see lots of spongiosis with lots of eosinophils. So the presence of eosinophils in epidermis and dermis points towards three main differentials. The first is an atopic condition. Number two is a drug reaction. And number three is an insect bite reaction. But in addition to these three diagnoses, there are a few other conditions which are associated with these features, which are the autoimmune conditions like bullous pemphigoid and pemphigoid gestationis, and even in Grover's disease, and in polymorphic eruption of pregnancy. Now, this is a picture in which spongiosis is associated with neutrophils. So presence of neutrophils in spongiosis, the first and the foremost diagnosis is the pustular psoriasis or psoriasis. The second diagnosis is dermatophyte infection. Then acute generalized inflammatory pustulosis, acute generalized exanthemic pustulosis, pedrous dermatosis, pustular contact dermatitis, and the only eczema that is typically associated with neutrophils and spongiosis is the seborrheic eczema. Here in this picture, you see the spongiosis as well as the inflammatory infiltrate, which is comprising mainly of lymphocytes. So the lymphocytic exocytosis is a feature of many different kinds of eczemas, which are usually of non-allergic origin. Now here you find that there is a lot of lymphocytes present in the epidermis, which are rather grouped together to form abscesses, which are lymphocytic abscesses, also known as the portrait-like microabscesses. And these cells are also of atypical shapes. So this is epidermotropism, a typical feature of mycosis fungoides or cutaneous T-cell lymphoma. This epidermotropism is different from this phenomena, which is called as the exocytosis. By exocytosis, it means that the keratinocytes are apart from each other, with the gaps between the keratinocytes due to spongiosis, and the inflammatory cells find these gaps as roads to enter into the epidermis, and this is called as exocytosis. But in epidermotropism, there is no spongiosis, and the lymphocytes enter into the epidermis by force, and this is how this epidermotropism is different from exocytosis. Again, a picture of mycosis fungoides. Here you can see many abnormal or atypical lymphocytes. The lymphocytes, when entering into the epidermis, they will have no connection with the surrounding keratinocytes, and there will be a big halo surrounding these keratinocytes. In stratum spinosum, we are also going to find if there is any keratin pearl formation or squamous eddies. Now we are trying to find the benign or malignant conditions involving the stratum spinosum. Are there any atypical cells present in the stratum spinosum? Or there are any mitoses? Or is there any population of cells in epidermis which are different from the usual keratinocytes? Now we are talking about the basaloid cells or poroma cells or clear cells. We have mentioned a clear cell pathology, that is clear cell acanthoma, but now we are going to discuss other conditions as well. This image shows hyperkeratosis, follicular plugging, and a few keratin pearls within the epidermis. In addition, the epidermis is, the keratinocytes in epidermis are rather thick and basaloid and having a lot of pigmentation as well. So this is a pigmented seborrheic keratosis. In this image, you can see that the whole of the epidermis is rather abnormally shaped. Cells are abnormal, their disposition is abnormal, and there's a lot of dysplasia, which is quite visible even at this magnification. So this is a full thickness dysplasia and is a feature of Bowen's disease or bovinoid actinic keratosis. In this image, you find lots of abnormal cells which are present in a group, small and larger groups, infiltrating this epidermis, and these groups, they are very different from the usual keratinocytes which are present in the epidermis. So this is called as the Pagetoid spread, and this is Paget's disease. Now these two images differentiates between the Paget's disease, in which the abnormal or atypical intraductal carcinoma cells are seen infiltrating the epidermis in groups. And here, the keratinocytes are indigenously, they are atypical, they are showing mitosis, they have abnormal nuclei, and these abnormally shaped keratinocytes are forming the usual desmosomal junctions with normal keratinocytes. So this shows the atypicality within the epidermis, and this shows infiltration of keratinocytes in the infiltration of atypical cells within in the epidermis. So the image on the left is Paget's disease, image on the right is Bowen's disease. In this image, there are two kinds of cells. On the left side, there are clear cells with sharp demarcation with normal keratinocytes. This is again a clear cell acanthoma, and here there are small, thick eosinophilic group cells in the epidermis, and these are the intraepidermal portion of poroma. These are poroma cells, and the type of poroma which is restricted only to the epidermis is called as the hydroacanthoma. This image shows papule with a crater containing the clear cells, and if these clear cells are present in form of a papule in a crater, this is a feature of tricholemoma, a follicular origin tumor which is associated with Cowden's syndrome. Now we have reached to the last layer of epidermis, and this is the stratum basal. Remember that the basal layer is columnar, and if the columnar cells are not present, it means that the basal cells have degenerated. So this will be a clue to you that if you cannot appreciate the columnar nature of basal cells, it means that there is some damage to the basal layer. And this damage can be in a form of vacuoles present in the basal layer called as the basal cell vacuolar degeneration. If you suspect basal cell degeneration, then there will always be pigmentary incontinence because the basal cells also contain the melanocytes. And if the basal cells are damaged, the melanocytes will also be damaged, and all the melanin which is present in the melanocytes will fall in the papillodermis. And sometimes the colloid bodies are also present. I've shown you one of the image. And if there is a lichenoid infiltrate or not. Lichenoid infiltrate, as I'll explain to you, is the band-like lymphohistiocytic infiltrate present at the dermoepidermal junction. This image shows thick hyperkeratosis, then hypergranulosis, which is quite significantly seen. Then there is hyperplasia of epidermis, but this hyperplasia is irregular, also known as the sawtooth epidermal hyperplasia. Then there is a band-like lymphohistiocytic infiltrate, and basal layer appear to be damaged at places. So this is a feature of lichen planus. If you go to higher magnification, you can see the columnar nature of basal layer is lost here, and the cells in the lower reaches of epidermis are polygonal in shape. These are the columnar nature of the intact basal cells, which are columnar, but they contain vacuoles. So this is the vacuolar degeneration here, and here the basal layer is completely lost. You can see a lot of pigment present in the papillodermis. You can see lots of pink cells which are present in the upper, which are the colloid bodies, and an infiltrate comprising of lymphocytes and histocytes, which are present at the dermoepidermal junction in a band-like way. So this is lichen planus. In this picture, you see follicular plugging, and the band-like infiltrate is present just beneath the follicles and not present in the intervening epidermis. So it means that the whole brunt of the disease is on the hair follicles. And this is a typical feature of lichen planopilaris. Had it been DLE, then this band-like infiltrate would not be restricted only to the follicles, but it would have been present beneath rest of the epidermis as well. This is the feature of discoid lupus erythematosus. You can see here that there is epidermal thinning. There is pigmentary incontinence. There is no band-like infiltrate, but the infiltrate is periadnexal. And there is follicular plugging as well, but not as typical as we see in lichen planopilaris. This is just the basal cell vacuolar degeneration. Basal cell vacuolar degeneration, and there are with pigmentary incontinence. And there are many conditions which is associated with basal cell vacuolar degeneration, and we call it as interface dermatosis. In the interface dermatosis, there is erythema multiforme, Stevens-Johnson syndrome, toxic epidermal necrolysis, and almost all the important autoimmune connective tissue conditions like SLE, systemic sclerosis, dermatomyositis. Even we see this interface change in acute graft versus host disease and in fixed drug eruption. And this interface change is different from lichenoid change, as there is a basal cell vacuolar degeneration, but there is no band-like lymphohistiocytic infiltrate at the dermo-epidermal junction. This unique picture has two features. The first is, if we see from the top below, there is parakeratosis as well as hyperkeratosis. Then you notice lots of gaps between the keratinocytes, which are actually the spongiosis. Then you notice loss of basal layer. Then you notice lots of pigmentary incontinence and band-like or dense lymphohistiocytic infiltrate in the papilloderms. So all these features are noticeable if you see from top to bottom. So this slide is a mixture of spongiosis and basal cell vacuolar degeneration and lichenoid infiltrate, and this is lichen striatus. Stratum basal contain melanocytes. So all the pathologies which are related to melanocytes originates from the stratum basal. So we need to see if, in case you are suspecting benign or malignant tumor of melanocytes, you have to look for the basal layer. Are the melanocytes present singly or in the nests? Is the nest of melanocytes atypical? Is the atypical nest of melanocytes in continuation with the nests in the dermis? Or is there any mitotic figure in the nests of melanocytes? So this is image is quite a typical image in which of freckle. Freckle is a condition in which there is only increased pigmentation of basal and suprabasal keratinocytes. There is no melanocytic hyperplasia. This is a picture of a lentigo. Lentigo is different from freckle, that there are two features, that is the epidermal hyperplasia and increased basal and suprabasal pigmentation. In freckle, there is only basal and suprabasal pigmentation, while in lentigo, there is epidermal hyperplasia as well as increased basal and suprabasal pigmentation. Now, this image is that of nests of melanocytes which are present at the tip of retiridges. These nests appear benign, homogenized. All of them have a similar look, and overall the picture looks benign. So this is actually junctional melanocytic nevus. Again, you see the nests of melanocytes at the basal layer, but these melanocytes are not present at the tips, rather they are attached to the sides of the retiridges, and there is no uniformity in the nests, and even the cells are not of uniform shape like here. The cells are of dysplastic shape. So now this benign condition has converted into a malignant condition, and this is the superficial spreading melanocytic tumor, melanoma. You can see here the nests of melanocytes are typically epithelioid shape, that is, they look like keratinocytes, they are round, But here, again, there are nests of melanocytes attached to the reti ridges, but these nests are rather spindle-shaped, comprising of spindle-shaped melanocytes. And this is lentigo-maligna melanoma. So lentigo-maligna melanoma is different from superficial spreading melanoma in that the melanocytes in superficial spreading melanoma are round or epithelioid in shape, while in lentigo-malignant melanoma, the melanocytes are of spindle shapes. These two images are a comparison of a normal benign-looking nest of melanocytes and an abnormal malignant nest of melanocytes, having both the cellular as well as structural atypia. Now I am going to stop here because I am already tired by giving a long lecture, and it will also be difficult for you to adjust the next portion of the lecture, digest the next portion of the lecture if I give the lecture right now. So I'll record the lecture that will be comprising of papillary dermis, reticular dermis, and subcutaneous tissue a little later. So hope to see you soon with second portion of my talk. Thank you very much and have a good day.